Hello, everyone. This is Amir Hajrasouliha. I want to welcome everyone to the cyber site. It's a pleasure being among the colleagues around the world. I'm Dr. Amir Hajrasouliha, retinal specialist at the University of Indiana School of Medicine, Indianapolis, USA, presenting clinical clues which would help us identifying patients with inherited retinal disease, followed by a new advancement in treatment of these patients with gene therapy and few potential other methods aiming to help this group of blinding disease. My talk would be followed by new drug discovery in the field of IRD by Dr. Yoshikazu Imanishi. My financial disclosure to the talk is listed on this slide. Inherited retinal disease are a group of clinically and genetically heterogeneous conditions, which consequently lead to blindness. IRD has a prevalence of 0.1 to 0.2% in general population. The IRD can affect pediatric through adulthood and present different throughout the life. Currently, more than 270 genes have been identified as causes of IRD, and the list is expanding each year. Across this group of disease, there is a great variability in degree of visual impairment, the impact of everyday life, disease progression, and the suitability to therapeutic intervention. Therefore, an early accurate diagnosis not only facilitates therapeutic measures, but also enables social psychological support to be sought at an early stage and may minimize the effect of disease on education and professional choices. RD can be difficult to diagnose, and they are important signs of presentation that can be clue to early diagnosis. Here I'm going to view a few of those signs, followed by sharing a few cases that showed up in our clinic. I'm going to start with the presenting signs in the childhood. IRD may present as nystagmus and can be a clue to predict the possibility of inherited retinal disease in the child patient. For example, this 7-month-old boy presented to our clinic complaining of nystagmus. On exam, he had fair fix and follow of the light. The horizontal nystagmus was present, and while the anterior chamber, iris, and lens was normal, he had no family history of any ocular diseases or systemic disorder at present. We saw this in the posterior pole exam, which showed pigmentary change in the fovea with drop out of the RPEs throughout the posterior pole. Periphery was unremarkable, and there's no pigmentary changes in the periphery. The genetic testing revealed a de novo variant of PAX6 mutation in this patient. Of 286 pathological mutation of PAX6, about 90% of them present with aniridia, and only 10% of them, like our case, are without aniridia, which showed isolated foveal hypoplasia or microphthalmia, or can present with optic nerve defects. So having a nystagmus without an aniridia was the clue to find out the IRD in this patient. What else can it be? Children might be afraid of dark and stop when they go to a dark room and say they cannot see. For example, this 5-year-old Hispanic male with general good health and no past medical history presented to our clinic with poor vision at night, and parents was noticing that he is afraid at dark and couldn't functionalize very well in a dim light. He first saw our pediatric ophthalmologist and then referred to us because of the retinal findings. He had no family history, born on term, and the best corrected vision was 20/50 on the right and 20/30 on the left. Posterior pole presentation was diffuse peripheral pigmentary change, as you can see, both in the right and the left eye, with loss of the outer retinal layer and only preservation of the central island. Genetic testing at this patient showed 2 RDH12 mutation, which transforms one from each parent. Mutation of retinal dehydrogenase 12 genes, or RDH12, maps on local chromosome 14, and is known as LCA13 as well. It accounts about 4% of autosomal recessive Leber congenital amaurosis. And as you know, LCA is early onset with severe retinal degeneration that affect 20% of children that attend the School of Blind. Other clues may be that direct the patient with proper diagnosis might be a failure in a school exam. This 6-year-old boy, which was generally healthy with no past medical history, failed the school entry exam and referred to us for further workup. He had no trauma, no significant past medical history, born at term, and the best corrected vision was 20/40 on the right and 2100 on the left. On fundus exam, noted to have these radial stria of the central macula, and the optical coherence tomography angiography showed the larger FAZ with dropout of the depot-capillary plexus and the schisis and the interretinal separation of the retinal layer and the spoke pattern. Genetic testing and the clinical diagnosis is consistent with X-linked retinoschisis with RS1 mutation. I have also seen pediatric patients being previously treated with amblyopia or strabismus being referred to us and diagnosed with IRD. For example, in this case, it's a 7-year-old boy who presented with vision of 2100 and 20/20. He was born at term with normal anterior segments and with intermittent XT, previously being treated for amblyopia, but last seen last month by a pediatric ophthalmologist, and because of the retinal finding, referred to us. On the retinal exam, he had a straightening of the blood vessels, displacement temporally of the fovea, and probably non-perfusion on the other eye, which was confirmed with fluorescein angiography, with multiple branching of the blood vessels even on the contralateral eye, and displacement and non-perfusion in the periphery in the right eye. So this was consistent with familiary exudative vitreoretinopathy with FCD4 mutation. Other rational and clues in diagnosis is syndromic features and positive family history. For example, someone with Bardet-Biedl syndrome and polydactyly and diabetes would be a referral to your clinic because of a known genetic background and syndrome to be evaluated for IRD. Presentation in adulthood could also be similar, but few clues in my mind would help us would be poor night vision, failing in the driving test, or positive family history that can lead us to proper diagnosis of IRD. Although clues can be helpful, sometimes it's very challenging, and the findings might be very subtle to diagnose the IRD case. I put this case up as an example of it. It was a 90-year-old boy, self-referred for evaluation of poor vision. He had always poor vision, which had made him being unemployed and depressed, and a smoker. And he had claimed that the vision had been bad from early childhood, but hasn't been changed for the past 5 to 10 years. On exam, he was 2200 in both eyes with normal anterior segment exam. Posterior pole showed optic nerve drusense with not much of a pigmentary change in the back of the eye. The foveal reflex was somehow preserved, and the left eye was showing just similar features of optic nerve drusense with maybe a little bit of a blunting of the foveal reflex, but no pigmentary changes in the periphery. Optical coherence tomography shows smudging of the central ellipsoid line in the right eye. Similar finding, you see it in the left eye with a little bit of a smudging of the ellipsoid line in the back. Fluorescein angiography is showing somehow a bullseye pathologic form with the optic nerve drusen shining up at the autofluorescence. ERG would be helpful in such a case, which showed a lack of cone response with preserved rod response, followed by the genetic testing, which confirmed the diagnosis of achromatopsia with CNGB3 mutation. Achromatopsia is a congenital autosomal recessive disorder characterized by reduced visual acuity, sometimes with pendular nystagmus and increased sensitivity to light, and photopsia with small central scotoma. The patient's visual acuity is usually stable over time, but both nystagmus and sensitivity to light may improve over time, which might be the time that the patient presents to you, as in our case. ERG is very helpful in detecting while the rod function is normal, there is a poor response in cone function. As we mentioned, about 1.1 to 0.2% of population has IRD, but frequency of genetic bioinformatics of human gene data suggests that 36% of population in different genetic background has at least one recessive IRD mutation, a value which is probably the highest among the Mendelian conditions in human. This dark area of this bars is showing the ABCA4 gene mutation. As you can see, this is really the highest prevalence among all the other genes. But the question is, why don't we see more of IRD when 36% of us have at least one gene mutation of autosomal recessive? And the answer is because we have more than 270 genes, and the chance of having the autosomal recessive form is much less. The journey of IRD does not start too long ago. It was only 70 years ago that we identified DNA as a genetic material passed by, and it takes 25 years to sequence the DNA, and another 30 years to build the PCR. And we had been able to do the human gene full sequencing for past 20 years. And we had identified 30 years take us to identify 270 genes associated with IRD. The pace of discovery has been rapid, with approximately 50 genes over 4 years for past 2 decades. But we should know that the genetic mutation is not equal to diagnosis and vice versa. Clinical finding of most IRDs are rarely pathocanonic of particular gene mutations. On the other hand, a given genetic mutation may result in a variety of IRD presentation. For example, these 3 cases that we have, they all look the same with the preserved central island and loss of the periphery, but they have all different gene mutation in all of them. So my question to the audience is, if you see a patient with IRD, what would you do? Do you do the genetic testing? The first poll is showing you're going to do it yourself. The second one, you're at least going to refer it to some colleague that you think they're going to do it, or you're going to only do it for LCA that you know that there is a treatment option for it. The fourth one, you definitely don't do it. And the fifth one, others. If you can answer this poll, I give 10 more seconds for us to finalize the answer. Well, interesting. So it's only 14% of us who are not going to do the genetic testing, and about 85% of us would do it. I want to put it as a comparison to what ASRS did in 2019 with the exact same poll. And 75% of specialists in the US would have done it. 70% of them would have done it, and 50% of our international colleagues. And you can see for the past 2 to 3 years how much more we are getting to know that the genetic testing is reliable and where we want to be. And this is with the help of having the gene therapy for at least one of the diseases that we know, which is the LCA with the RPE65 mutation. But there are some limitations to what we can do. There are currently about 20 active trials of gene therapy for IRD going on. But how much baseline and what's the limitation of these kind of therapy? One of them is the presence of the pathology. For example, in the X-linked form of RP, there's too much of damage to the outer retinal layer, and would therapy late in the disease would help us to achieve what we want. The other challenges in the gene therapy would be how much immune response we would have. For example, in the form of the treatment of RPGR, we know that the perimetry would be helpful in identifying the progress of the immune response depicted by the subretinal deposits in these patients. While the vision on the best corrected vision on the letter hasn't changed, the perimetry is changing, showing that we have to come up with new tools to identify the success of the therapy as well as perimetry. The other things which is challenging is the dissociation between the structure and function. While we thought someone with the achromatopsia, which I presented, might be a good candidate for treatment because the preservation of the structure, our treatment had shown the improvement had been limited in success. And that might be due to other things like amblyopia and not being able to differentiate the color from early childhood with the pathways of brain not forming. Other challenges that we have is while we have 20 genes that's being tested, there are another 250 genes which needs the treatment. And here it comes the other approaches that comes into mind and the methods that Dr. Imanishi would discuss about, which would help us with a larger group of IRD patients. There are many other interesting approaches, including the prosthetic retina, which has been approved with Argus 2. But there is the limitation to the availability and cost of those approaches as well. So in summary, want to point out that although the gene and genetic therapy shows promise, we have to work more, and genetic testing is becoming more and more available and acceptable in clinics. And we need to come up with the treatments that can treat more groups of IRD patients. I want to thank you for your attention, and I want to pass my talk to Dr. Imanishi, who is going to talk to you more about the new drug discoveries in the field.
In the latter half of this webinar, I would like to talk about the contemporary drug discovery studies for inherited retinal degeneration. And as Dr. Hajrasouliha mentioned, there are a number of adeno-associated virus vector for gene therapy that are being developed. And particularly for this topic, Dr. Alex Levin covered those stem cell therapy and also gene therapies last year. So I delegate for those who are interested. I encourage you to view those recorded webinars. And in my talk today, I would like to address approaches that can target multiple inherited retinal degenerative disorders independent of the gene mutations. And I have no conflicts of interest concerning commercial entities to disclose. And also I want to mention that most of the therapeutics or investigational therapies I'm going to mention are currently under preclinical or clinical development. Therefore, they are not yet approved by FDA for patients with IRDs. But I would like to give you some encouraging evidence that there are certain evidence that those approaches work. So in the majority of inherited retinal degenerations, and photoreceptor neurons are most important because those photoreceptors either become dysfunctional or die over time. And there are two types of photoreceptor cells, rod and cone photoreceptor cells. Those cells are so important for our vision because within those cells, photons are received by molecules called as visual pigments, rhodopsin or cone visual pigments, and absorption photons by those molecules lead to a cascade of biochemical reactions within the cells, leading to the activation of G protein called as transducin and activation of phosphodiesterase and hydrolysis of cyclic GMP to 5' GMP. These changes in the cyclic GMP concentrations are sensed by the cyclic GMP gated channels located to the surface of the cells. And when people acquire gene mutations to have inherited retinal degenerations, in the majority of them, what happens is that those rod photoreceptor cells become sick. And so in many cases, those rod photoreceptor cells become less functional than those in the healthy individuals. Therefore, people have visual impairments. And because of these changes in the function of the rod photoreceptor cells, those cells have increased the probability to die. So dependent on the gene mutation, those photoreceptor cells die rapidly or slowly or stay as they are. But so those depend on the gene mutations and also environmental causes. So if enough number of photoreceptor cells are lost, and then those patients become profoundly blind. So for us to be able to see the light continuously, those rhodopsin molecules need to be activated. This activation requires this 11-cis retinal within the rhodopsin molecules to be converted into all-trans retinal. And this all-trans retinal gets converted again eventually into vitamin A and transported to the neighboring cells, such as retinal pigment epithelial cells or microglial cells, where those vitamin A molecules are converted back to the 11-cis retinoid and then transported back to the photoreceptor cells to conjugate again with opsin molecules to form rhodopsin. And this continuous recycling process is called as the visual cycle and critical for our vision. So that once we understand the biochemical basis of vision, the question arises that is it possible to develop therapies for multiple blinding disorders or inherited retinal degenerations? So, for example, in this pathway, there's a side reaction that converts those all-trans retinal molecules into something called as bisretinoids. And this process is considered to be detrimental to the vision because this bisretinoid prohibits the functions of retinal pigment epithelial cells, and this overaccumulation of this molecule is considered to be detrimental. However, for example, a molecule Dr. Hajrasouliha mentioned, ALK001, can inhibit this process of the retinal conversion into bisretinoid. So bisretinoid is a conjugate of two all-trans retinal molecules. And so there's a therapeutic approach to inhibit this pathway. And there's another approach being developed to inhibit the entrance of vitamin A into the retina. And this can decrease the amount of retinoid or vitamin A molecules with cycling in this pathway. Yet another possibility is to inhibit the critical enzymes in the pathway. So there's an approach to inhibit the enzyme called as RP65 to decrease this activity and then decrease the amount of bisretinoid to be produced. So currently, there are a number of clinical trials ongoing for the indications such as Stargardt disease and age-related macular degeneration and diabetic retinopathy, targeting this pathway. So then the question is that once we understand the biochemical defects, we will be able to target those pathways to ameliorate the retinal degenerative conditions. So I would like to cover those three ideas listed here. First is targeting common pathways promoting photoreceptor degeneration, and metabolic reprogramming and neurotrophic factor ideas, and also preventing the degradation of mutated proteins that are functional but unstable. So I'll start from the first. So as I mentioned earlier, those photoreceptor cells are essential because of this phototransduction cascades. In a subpopulation of the inherited retinal degeneration patients, people have mutations in the genes encoding the components of this pathway. For example, in a large fraction of the autosomal recessive retinitis pigmentosa patients, mutations are seen in the genes encoding phosphodiesterases. And also, in a small fraction of those IRD patients, mutations can cause overaccumulation of this protein called as guanylate cyclase. And as Dr. Hajrasouliha mentioned, in a subfraction of the achromatopsia patients, cyclic GMP gated channel gene is mutated. In all those conditions, what's going to happen is that the cyclic GMP concentration goes up. For example, when phosphodiesterase cannot hydrolyze cyclic GMP goes up. And this leads to the overstimulation of a protein called as cyclic GMP-dependent kinase or protein kinase G. And this stimulation is considered to be detrimental because this will activate the apoptosis of the cone or rod photoreceptor cells. Therefore, a group of investigators led by Dr. Francois Paquet-Durand developed multiple cyclic GMP analogs with the aim to inhibit protein kinase G, PKG, in photoreceptor cells. So they synthesized cyclic GMP analogs and subjected those molecules to a cell-based assay, basically assessing the survival of rod photoreceptor-like cells derived from the mutant or IRD animal models. And as a second step, they assessed 6 molecules to in the organotypic explant culture assay to confirm that those molecules can, test if those molecules can promote the survival of rod and cone photoreceptor cells. And moreover, they tested if those molecules can alter the calcium signaling in cone photoreceptor cells. And any molecules that affect the calcium signaling are considered to be suboptimal because those molecules are potentially targeting the cyclic GMP-gated channels that are critical for our vision. And eventually, they came up with a molecule called as CNO3 and also liposome formulation CNO3. This formulation facilitates the delivery of this molecule to the retina. So they tested this molecule in an animal model of inherited retinal degeneration with mutation in the phosphodiesterase gene. Those models are called as, this model is called as RD10. And quite encouragingly, this molecule can significantly promote the survival of rod photoreceptor cells as shown here. So this thick layer is photoreceptor cell layer. And this effect is observed throughout the retina in this, as shown by this blue line here, compared to the untreated cohort of animals. So there's encouraging evidence that once we understand the biochemical basis, we will be able to target this particular pathway to delay the photoreceptor degeneration. So the question is, are there other common pathways we can target? So one of the pathway could be metabolic pathway involving the glycolysis. So those rod and cone photoreceptor use glucose as a major nutrient. So in the retinitis pigmentosa, glycolysis is compromised both in rod and cone photoreceptor cells. One reason is because in inherited retinal degeneration, a lot of photoreceptor cells, especially this region called as outer segment, gets shorter or become lost from those cells. And then rod photoreceptor cells cannot interact effectively with RB cells, which transfer glucose to those cells. And when rod photoreceptor cells die, those cells cannot secrete neurotrophic factors called as RDCBF, which bind to the surface of cone photoreceptor cells, resulting in the promoted glycolysis because of the promoted transfer of glucose to the cell. Therefore, this loss of trophic support by rods can lead to compromised glycolysis in cones and eventually death of cone photoreceptor cells. And Therefore, there's an idea to deliver this RDCBF factor to the retina by using, for example, adeno-associated virus. And such approach is currently under preclinical development, and I believe I think those therapy will go into the clinical trial very soon. Another idea concerns about the regulation of gene transcription, and this factor called the SAT6 histone deacetylase is known to bind to the gene upstream region of the genes dictating glycolysis. And in the presence of this gene SAT6, those glycolysis associated genes are downregulated or suppressed. But when this SAT6 function is compromised or removed from the cell, those cells can now transcribe those genes very effectively, promoting glycolysis. This idea was taken by Dr. Stefan Zhang's group, who tested this idea using the newly developed this PD6B mutant animal model, which demonstrates very rapid photoreceptor degeneration within a matter of 2 months. But when this SAT6 gene is removed from the rod and cone photoreceptor cells, what happens is that the photoreceptor survival is significantly promoted, along with the improved rod and cone photoreceptor functions, as shown by those electrophysiological study. Therefore, metabolic reprogramming is not really particularly specific to the gene mutation, because in many IRD, for example, at least at the level of animal models, the glycolysis is known to be compromised. Therefore, this is potentially applicable to multiple inherited retinal degenerative conditions. And last but not least, I would like to cover the topic about preventing the degradation of mutated proteins. And this approach stems from the fact that a large fraction of inherited human disorders are caused by point mutations in the genes. And for example, so when patients acquire this, patients have this mutation, a wrong amino acid is incorporated into the polypeptide chain of a specific protein, such as rhodopsin, phosphodiesterase, RB65, or genes associated with Usher syndrome. And what's going to happen is that those proteins become partially misfolded and then degraded by the cells using the machinery called as proteosomes. Therefore, my group particularly focused on Usher syndrome type 3 because this disease is characterized by progressive loss of vision as well as hearing. Therefore, there might be an opportunity, window of opportunity for treating to delay the degeneration of those neurons, sensory cells in the system. So we devised a new method for identifying stabilizers of specific mutant proteins. And this approach depends on a mammalian cell line that was designed to express a red fluorescent protein, which was designed to be degraded by proteosomes. And also another reporter, which is a curarine one, an N48K mutant protein, which is causative to Usher syndrome type 3. And this gene, this protein was fused to a green fluorescent protein. But both those proteins are very unstable and degraded by the proteosomes. Therefore, under normal conditions, we don't see much fluorescence. But if we were to inhibit proteosomes, what's going to happen is that both red and green fluorescence go up. If we can find out a specific molecule that can stabilize curarine 1 protein specifically, and we'll be able to increase green fluorescence only. We conducted this assay because proteasome inhibitors are known to be toxic to photoreceptor cells. Therefore, we wanted to screen out, remove those molecules from the candidates. So this screening effort, we screened for about 50,000 molecules. And if we don't do anything to the cell, we don't see much fluorescence. If we inhibit the proteasome machinery, we see increase in both green and red fluorescence. But out of those 50,000 molecules, we found that at least, I believe, 20 or 30 molecules stabilize the clarin-1 protein, but also through the inhibition of the proteasomes. So we didn't pursue those molecules. Fortunately, among 50,000 molecules, we are able to identify only one molecule we named as O3. Therefore, we worked with a group of medicinal chemists to improve the structure of this O3 molecule. And eventually, we came up with this new molecular entity called as BF844, which was effective in stabilizing clarin-1 proteins. So we also, at the same time, developed an animal model of Usher syndrome type 3, a mouse model. And unfortunately, this mouse model didn't develop vision loss, but this model developed a significant hearing loss. Therefore, we used the hearing loss as a surrogate to test the efficacy of this BF844 molecule. And so, for example, so this is a mouse model, and those mouse models are profoundly deaf, which here profoundly deaf. Therefore, this sound pressure level threshold is very high. But wild type animals, normal animals can hear very well, so they can hear very low level sound. And if we give the BF844 molecule to this mouse model, we are able to significantly preserve the hearing by the factor of, so their hearing performance was at least 1,000 to 10,000 fold better than the mice that were not given this treatment. And so this is a concept of the proteostasis therapy stabilizing the mutant protein. So in the case of BF844, we can inhibit the degradation and increase the protein amount and promoting the folding of this protein. And there are other potential investigational therapies being developed. For example, sodium 4-phenylbutyrate is called as chemical chaperone, which was tested on a mouse model of LCA, liver congenital amaurosis, caused by RP65 mutation. Pharmacological chaperones are being developed for IRDs, for example, caused by rhodopsin mutation. As I mentioned earlier, rhodopsin binds to 11-cis retinal, so retinoid analogs mimicking those structures are potentially effective to stabilize the structure of rhodopsin molecules. So their approach is quite successful in preventing photoreceptor degeneration in at least at the level of animal models. Although I didn't mention extensively, some of the mutations introduce a stop codon instead of the long amino acid. Those are called as a nonsense mutation, leading to the incomplete polypeptide to be expressed in the cells. So there are efforts to develop a read-through inducing drugs. Those drugs bind to ribosome and basically replace non-stop codon with another amino acid coding. So they can translate a non-stop codon into amino acid, allowing the polypeptide to be synthesized. So such approaches are developed for indications such as Usher syndrome type 2A and 1C. Therefore, so we started from this question: what does one size fit all to all the IRDs? The short answer is no, but the field is evolving to develop therapies collectively addressing the wide spectrum of IRDs, and the therapies can be potentially tailored in accordance with biochemical or cellular defects that are shared among different IRDs. With this, thank you very much for your attention, and we are open to questions. And I'm listing here the email addresses of me and also Dr. Hajrasouliha. So if we cannot answer sufficiently your question at this today, please send us an email so that we'll be able to answer. Thank you very much for your attention.
Thank you, Dr. Imanishi, for great talk and going over the discoveries and new modalities of treatments of more patients with IRD. through the registration, there were a few questions that I highlighted, which was repeated, and I thought we might be able to discuss that. One of them was, can a bionic eye be used in situation where the retinal degeneration is vision threatening? Yes, as we discussed, there are few modalities of using artificial retina, which has been FDA approved. The clinical use of them are very limited, and only few sites are approved to be implanting those. And as the others had been pointed out in their questions, the cost of treatment is also challenging, especially for developing countries. There was another question is, how can this be applied in developing countries? And I think part of Dr. Imanishi's talk, which is drug discoveries and the modalities that can be used as drug delivery, which rather has less complicated approaches and probably more broader audience or patient population that can be treated by it, would help us to lead that way in the treatment options.
And also, I would like to address a few of the questions. And there was a question that is acetylcysteine will be a new choice of treatment for retinitis pigmentosa. And actually, there's an idea to use acetylcysteine. Acetylcysteine is considered to be antioxidant because this is a precursor of glutathione. And actually, when the photoreceptor cells are known to be the region with very high oxygen concentration, and so when a lot of photoreceptor cells die, it's considered that cone photoreceptor cells are exposed to high level of oxygen. So N-acetylcysteine is considered to be beneficial, and I believe this is under the clinical trial led by Johns Hopkins University, as Dr. Hajrasouliha mentioned.
So there's a question, what's the clinical clue to differentiate between the Stargardt and cone rod dystrophy? So this is where we go back to the knowing the genetic mutation is not equal to diagnosis and vice versa. So as we discussed, and we label different diseases as cone rod dystrophy, LCA or RP, there are many features that are common among the same mutations. So ABCA4 can be a cause of cone rod dystrophy, and Stargardt's also a known cause of it can be ABCA4 as well. Doesn't mean that other forms of conditions cannot be named as such as well. So it is a gray zone of clinical diagnosis versus the genetic diagnosis as well. And as we know more and more about the genes, the naming of the disease would be a little bit more difficult to catch up with. The question is any of these drug has been in the market yet? No, there's no FDA-approved drug yet in the market. As we discussed, there are some trials with medication. Our site is an active site of recruitment for the ALCO-01. It's a medication which is similar to vitamin A, but is trying to reduce the junction and fusion of two vitamin A to form a biformate form, which is thought to be less toxic in those patients. Still on the clinical phase 3, but not available in the market.
And I think there was a question. So what are those in the pharmacy profession can do to contribute to the field? And I believe that people in the pharmacy profession can educate the patients in terms of the potential side effect of the therapies prescribed to those patients. Because, for example, as I mentioned, phosphodiesterase gene product phosphodiesterase is, for example, inhibited by pharmaceuticals such as sildenafil, and that's a side effect of like vision defect, of temporal vision defect. So that you want to educate in some of those medicines are contraindicated to the inherited retinal degenerative disorders.
Thank you all for your attention. And as Dr. Imanishi mentioned, if you had any further questions, we would be happy to answer them through the email.
Thank you very much.